Yes, hello. We are online, and it's a nice Friday again, and I'm very happy to be in studio together with our bariatric surgeon, Dr. Olegs Kozlovskis. The doctor is general and bariatric surgeon, working with bariatric surgeries for 10 years already. And many of you have seen him, have met him, and have been in very close cooperation for the surgery. Others are still waiting, and many of you are still thinking about the surgery. So as there are many questions about the types of surgery, so I'm very happy we have this possibility to invite the doctor, the surgeon who does the surgeries himself. So, and we were kindly asking him to tell about the surgeries from the surgeon's perspective. And today we're going to speak about sleeve gastrectomy operations, what type of surgeries is, what changes are being done during the surgery, and what consequences are for the patient after the surgery. So let's meet Dr. Olegs Kozlovskis. I'm very happy. Hi.
Hello, everybody. It's very nice time to meet you, everyone online. And today our topic, a little bit, which we will talk about, it's sleeve gastrectomy, and about procedure and all these possibilities, what we can do, and why people choose sleeve gastrectomy. In one case, we can do the procedure. In one case, we have to switch to another procedure. Have to start that sleeve gastrectomy. It's a very nice procedure. It's quite common in the world, and a lot of surgeons do sleeve gastrectomy. I also like to do sleeve gastrectomy. Very interesting procedure, and procedure happening under general anesthesia. Patient are completely asleep, and as soon as the patient is sleeping and feel nothing, we can do the procedure. I will go with the steps during this procedure. I will try to explain all the steps, why it's necessary, and you will have imagination what we're doing inside. We are not going to show a video that time, but we show some build with some steps of the procedure. So first of all, we have to introduce trocars inside in your body, and usually we are using 5 keyholes. Its procedure is laparoscopic. It means that everything what we are doing inside in your body, we are looking on a big screen, and organs are very well introduced on these images. So we are putting, we are making small cuts. There are usually 5 cuts. Sometimes it's necessary to add one more instrument, and it's 6 cuts. Sometimes if liver is not very big, we are using just only 4 small keyhole scars. So first of all, we are introducing video trocar, and it's going through all layers of your abdominal cavity until we are reaching abdominal cavity, and we put CO2, it's gas for inflation of abdominal cavity inside. This gas is very necessary to create a space for moving instruments and for doing the procedure. Are you hearing me? Everybody is online?
Yes.
Yes. So as soon as we are creating a space, we are putting a video camera inside. It's usually 10 millimeters camera, and we have to look all the visible organs if everything is okay. First of all, we are looking on the liver. Liver side is very important for the surgery, and for obese patient, liver can suffering for steatosis hepatis, and that's why one of the reasons to preparing for the surgery is reducing 5, 6, 7 kilograms before the surgery. So this liver side, left liver side, is getting smaller and it's possible to hold it up. After liver, we are looking around all the organs inside if everything is okay, because sometimes we have to cancel surgery because of the findings inside in your body, like some tumors, for example, in some other parts, in some other organs of your body. So if everything is okay, we put another trocar, and it's trocar with special hook or lever retractor, and we are putting this instrument behind the ribs and putting up lever. It's very important to create space for operation. It's second trocar. After, we are putting 3 more trocars. It's for walking instruments. So as soon as trocars are ready and space are created, we are starting to do the procedure. First of all, we ask anesthesiologist to deflate stomach, because during the intubation, it means when anesthesiologist put tube in your windpipe for ventilation. During this time, also anesthesiologist putting tube in your stomach, and in the stomach can be air, and this air has to be deflated. So stomach have to be empty during the procedure. That's why we're asking additional anesthesiologists to take all this air out from the stomach if it wasn't there. So, and first of all, we are looking for pylorus. Pylorus is special muscles which is between the stomach and duodenum, next bowel, which is going straight away after the stomach. And we measure 2 to 4 centimeters away from the pylorus and make a mark on this lens, because this mark, it will be where we are going to make first stapler, where we are going to put first stapler. So when this are noticed, when this is clarified, we are starting to mobilize greater curvature to divide stomach from blood supply from greater curvature. I will show you a small photo where it's possible to see, and I will ask Ilva to help me if it's possible to see on online screen. Is it visible?
Yeah? It is.
Okay. So pylorus, which I mentioned, is located here. So this is big stomach, and this is big sac, which is possible sometimes to fill in with a lot of food. And straight away after the stomach, there is duodenum. There is the next gut, which is going after the stomach. So we measure from the pylorus 2 to 4 centimeters, make a mark here, and after that we're starting to divide greater curvature. There is along the greater curvature is a lot of small blood vessels, but stomach have got a very nice blood supply. It's a very good supplied organ. So, and we need to divide all the stomach along this greater curvature. There are some few very interesting steps. You cannot go very closely to the pylorus, because in this situation you will make problems for blood supply for this region of the gut. You need to go along, as a next step, you need to go along this greater curvature, and here in this region located spleen. It's very big and very well supplied organ, and you have to divide stomach from some adhesions with the spleen, and stomach have got few vessels which just go directly to the spleen, and this is a very important point during the operation. So the next very important point, when you are going up, you have to mobilize all this length and to reach esophagus. This part we call esophagus, and to reach diaphragma left crura. There are some muscles and some hole where esophagus goes through diaphragma. So during the mobilization, you have to complete full mobilization until this left crura. And also behind the stomach, when you put it up, there can be some adhesion with the pancreas. Pancreas is located straight away behind the stomach, so in this region. So this I think it's a very important part of operation. When you are doing this mobilization, you have to very clarify this all the anatomical structures, and stomach have to be very mobile. As soon as it is done, the next step is that we are insert special calibration tube in a stomach. It's have to be inserted inside. I usually try to put it forward a little bit behind the pylorus to the duodenum. I find it very important that it's not moving free inside in the stomach. So I try to put it here and there behind the pylorus and left it there. So in this region, before we are doing cutting, we are insert special calibration tube. It's very necessary and very important to make nice calibrated tube of your stomach. So as soon as this is done, we can start to divide stomach in two parts. So 2 to 4 centimeters away from the pylorus, we are putting special stapler which contains 6 range of titanium with vanadium and little bit I think aluminum, if I'm correct, because we spoke with provider of these staplers. They are very, very good provider, very well-known firma. So the inert metal which is going through all the layers of your stomach. When I close it, I'm looking very carefully if both sides are equal. It's necessary that all of the sides are equal, and have to put in this direction along this calibration tube. So usually it's take 5, 6, sometimes 7 staplers to gun and to put on and to gun on until up. So we are putting, everything is okay. We are putting one, after that another one, and we are creating so small narrow tube which we call sleeve, and it means sleeve gastrectomy. So as soon as it's done, this part of the stomach became free of blood supply, so this part have to be removed. But before we're doing that, we are looking carefully on this suture line, and sometimes there can be small bleeding from small vessels. We have to stop this bleeding. Sometimes we put some clips on. Sometimes it's require one additional stitch to put on, and we have to be know that all these suture lines are very nicely closed, and there is no any dehiscence or any problems with this line. We ask anesthesiologists to put some fluids in this tube. We close here with the instrument, and we increase a little bit pressure in this tube and look if there is some leakage. Before finishing, we have to be sure that this suture line is very nicely done and there is no any problems with the suture line. Sometimes it's required to put some stitches there or there to reduce possibility to be for this stomach to be twisted. I think it's very important stitches which can hold the stomach in position which the stomach have to be. If everything is okay, we can remove this big part of the stomach away. Usually, I use right-hand trocar to take this away. We make a little bit bigger scar and opening a little bit more muscles and taking this stomach away through all the layers. Sometimes it's necessary to put additional stitch on these layers and to close it a little bit more carefully. If it's I check this hole, and if it's too loose, I prefer to put some stitch on. I noticed that next day after operation, if I put this stitch on, some people complain about a little bit more pain as usually, because all the muscle layers are stitched on. So as soon as this whole part is removed, I have to check one more time is everything is okay with this sleeve gastrectomy. So if there is no any bleeding, if everything is dry and everything is okay, we are removing all the instrument off. So of course, carefully we have to look on these K-holes, because sometimes these K-holes can cause a trouble for us as well. So bleeding can be also from all these K-holes. And before the taking off the trocars, have to look on this holes and to manage if they are bleeding, have to stop it. So is it interesting so far?
Yes.
Yeah.
Yes.
For you only, or for everybody?
There are still no questions, but people are watching, so we're going on.
Yeah, a little bit water.
It's good. Good.
Sorry. So this is the main steps of operation. Usually operation take around 40 minutes. It's possible to do a little bit faster. Sometimes it's a little bit longer time. Of course, narcosis times it's half an hour before and a little bit time after, because people have to be awake after the operation. So how much? Usually people ask me how much you are going to remove the stomach. It's approximately from 75% till 85% of your previous volume will be removed. But each stomach is a little bit in a different size. I met men with quite small stomach, and I did operation for ladies which stomach is very big. As I told before, we use usually 6 stapler, but sometimes it can be 5, sometimes can be 7. How much you can drink after operation? Usually volume after operation is around 100 milliliters. Maybe a little bit more, 120, but it's generally it's around 100 milliliters. So stomach can be filled with half of your cup usually. So any questions about sleeve gastrectomy, about this procedure?
I will ask the questions. People are saying that it's very interesting to listen, so it's good. I think the most common question is, well, which type of surgery to choose, because some people have done to research by themselves and think that they know the best type for them. But mostly people are still asking which type of surgery is the best for them. Is it sleeve or bypass? Well, we're discussing these two types at the moment. So what are the reasons to choose the sleeve rather than bypass? Maybe you can name some reasons.
Yeah, very interesting question, and usually people asking, "Oh, can you advise me what procedure I have to do?" So it's also very complete questions because each person are different, and all this decision have to be made when you have all examination done before. And very important examination is fibrogastrectomy, when before the operation with this special narrow tube is checked all the stomach and esophagus and also duodenum inside, if there are some problems or if everything is okay. And this is one of the main reason why I am looking on this fibrogastrectomy, and only after that I can make a decision what to do. So, for example, sometimes we can find some small polyps in a bigger part of the stomach. And these polyps, if we do bypass procedure, will be left it inside in this remain part of the stomach. So more likely in this situation, I would advise for patient to do sleeve gastrectomy, that during this time, these polyps will be gone away. Of course, if it's just only one or two polyps, usually it removed during the gastroscopy procedure. And in this situation, we have to delay operation after few weeks or months when this part is healed normally. But if it's more than two or three polyps, we have to remove. So sleeve gastrectomy, it's could be a reason. But of course, if on the remain part of the stomach there are no any other polyps which will be left it inside. So another reason what I'm looking for, if it's reflux, signs of reflux disease. Reflux, it means when stomach content is going up back to the esophagus time to time or many times in a day, and a lot of obese people suffering from this condition, and it's make a lot of disturbance for patients. So in this reason, I would advise to do gastric bypass procedure, because in gastric bypass procedure, reflux is much more less possible if we compare with sleeve. So another point of view, what I'm looking on, it's a previous operation on the stomach. For example, if patient had a few cesarean section, a few hernia repairs, sometimes other surgical intervention, more likely that it will be possible to do only sleeve gastrectomy like a procedure, because in bypass it's necessary to move bowels up and to change bowel position in abdominal cavity. Another reason for sleeve gastrectomy, if it's super obese patient and if it's very difficult to do bypass, because in bypass operation it's a lot of sewing by hands necessary to do, and a little bit more challenging procedure. I like bypass very much, but in this, if it's a lot of adhesion inside, of course we are trying to divide adhesions, and also if patients are very big and it's not possible to move instruments, because sometimes it's very hard to move the small instruments inside in your big body. It's also can be a main decision like second second step or two steps operation. Like first step, it's sleeve gastrectomy, and after patient reducing the weight, we can think about if it's necessary to do another procedure or it's not necessary to do another procedure.
Right.
And one, yes, really, yeah, come on.
We have questions. I know you do not have 2 hours for us.
Yeah, okay.
Yeah, sorry, I interrupted you. So
It's
do you
okay.
have?
Go.
Okay. So can we start with questions, or there was another reason you wanted to tell?
Yeah, I wanted to tell one more reason. If young lady thinking about the procedure, and if young lady also thinking about in the future for giving birth for child, and BMI is not very high and some comorbidities, I would also advise to do like sleeve gastrectomy, because sleeve gastrectomy is physiological procedure. What does it mean? It means that all the guts, all the organs are in the same position like it was before the procedure. Bypass, it's diversion of the food, and in young ladies in small BMI, I would advise to do sleeve gastrectomy. Yeah. Yes.
Thank you. Thank you. So we've got a question about band removal and then doing the sleeve gastrectomy surgery. Is it?
Yeah.
Which procedure would be recommended after the band? Or
band, it's sometimes have to be removed, and with the years 50% of the band are removed for patients who are done. And now it's not in Europe, at least it's not a very common procedure, and we are not doing band procedure like only procedures in our hospital, but we are removing bands. So during the removement of the bands, it's necessary to divide all adhesions around the stomach. Usually the stomach is, how can I say, it's a change in anatomical situation because of these adhesions, and have to all this adhesion to divide and to find and to get back to the normal anatomy at once. Another one, muscle of the stomach, it's before the band, it's hypertrophic because of all the time stomach is putting down this food to the rest of the stomach. I would like to do after band procedure gastric bypass to create a small stomach, to create nice pouch and connect with the small intestine. Sleeve, it seems to be a little bit more how can I say, tricky procedure, because upper part, if you remember, I show you this part of the stomach. I will put this one more time, this picture on. Can you see this picture, Ilva?
not yet.
It's just a moment. Okay, and now?
No.
No. Share the screen, yeah.
Share the screen.
Mm-hmm. Just a moment, and sorry, I cannot put it one more time. It was deleted somewhere.
I can share on my. I will try to
Yeah,
catch.
maybe. Yeah, if you can do it, Ilva, for me, it will be very nice. Yeah.
Mm-hmm.
Yeah, you can see, and if you can put on the upper part of the stomach, which just divide it a little bit. Where the suture line? Yeah, this part. Yeah. Where's the suture line? Yeah, you're correct. Yeah,
Mm-hmm.
this part, it's for us, for surgeons, are quite dangerous part because leakage occurs in this part more likely than somewhere else. Another part is quite close for pylorus, but this upper part is a very tricky part, and there is located band after band operation, and all the layers and stomach serosa can be damages in this part. That's why I prefer to do bypass after removing the band. Any other question?
Okay. Yes. How true that after a couple of years, the patient could regain all the lost weight with sleeve as opposed to the bypass, which is more long-lasting?
So we know sleeve gastrectomy approximately 10 years. I mean all around in the world. There is no result, long-term result, if we compare with gastric bypass. Gastric bypass can be 25 years results or so, but we know also that weight regain can be with all procedure. Bariatric surgery is a tool which we surgeons giving to you, and you need also to change your eating behavior, your physical activities. It's like a tool which helps to lose the weight. And with 2 or 3 years after operation, patient starting to eat a little bit more than they have to eat. They start to lose physical activities a little bit more. So it's weight regain is very complicated questions, and of course can occur, and I would say 5 to 10% after operation, but it's have to remember that you need to do you need to change eating behavior, you need to do physical activities all your life to be in normal weight.
Yes, thank you. The next question is about the acid reflux after the sleeve surgery. So we were discussing it. How many sleeve patients develop reflux, and do you know of any surgical techniques to decrease the likelihood of developing it?
Yeah, this is another problem for sleeve gastrectomy, and can occur up to 30% of a patient after sleeve gastrectomy. Usually it's somewhere around 15 to 20%, but some researchers show us that it can be up to 30%. And this is one of the main questions where Surgical Society we are speaking about, and we are waiting long-term result after sleeve gastrectomy to see how often this reflux will be in 10 years or in 15 years after sleeve gastrectomy. So technical points, you don't have to do very small tube, very straight tube. So this will so it's have to be like loose sleeve, and also the sleeve don't have to be too small and don't have to be too big. That's why we are using calibration tube and going along this calibration tube. There are some operations which are showed on world congresses, but like fundoplication with the sleeve, but it's still unclear if it's will working like anti-reflux surgery.
Okay, and we have one more question about larger patients. Why the gastric bypass surgery is more suitable and recommended more for larger patients?
Yeah, gastric bypass still gold standard for bariatric procedures. Gastric bypass, it's very interesting theme. Probably we will speak about gastric bypass a little bit more next time or in few weeks time. Gastric bypass more suitable for my opinion, because in a gastric bypass we are doing also like malnutrition procedure when we excluded part of the bowel from the digestion, and this point have a little bit more benefits to reducing weight.
Okay, so I can't see any more questions, and I know you're running out of time, so I think we can thank you for your time and for a very nice conversation, and I hope we are looking forward to do the same with the gastric bypass surgery. So I think it's also very that you are saying already, it's a gold standard still, and it's very worth to discuss it. So thank you very much. I think we will finish today. I saw many people were watching and listening, and many will do later, so during the day. And have a nice day, and thank you, and see you next time again.
Thank you, Ylva, and thank you everybody for spending time with us. Bye-bye.
Great. Bye-bye.